Hello, welcome to today's webinar about the role of biomarkers in female hormonal health and fertility, presented by Dr. Jorge Rodriguez-Purata. He is Scientific Director at the Assisted Fertilization Clinic at Hospital ABC Santa Fe in Mexico City. He is a gynecologist and obstetrician specialized in assisted reproduction from the Dexeus Institute in Barcelona, Spain. He has published multiple articles and authored more than 50 research papers. Welcome, Dr. Rodriguez-Purata, and thank you for being here.
Thank you, Christian, for the invitation. I'm so happy to be here. So happy to be able to talk about what we do every day on a fertility clinic. But I guess what we were thinking when we decided this topic is that it's something that is very useful in the general consultation and gynecological consultation, and I hope it makes sense for you guys. So there's no question that fertility is becoming a challenge. We hear more and more about couples trying to conceive and having difficulty trying to conceive, and this has been in our society for a few years. And the problem is that this is going to continue. What the epidemiology research shows is that by 2021, by 2050, 2100, it's going to be crazy about how many babies are actually going to be born. We are going to have a problem in terms of population in a few years. And this in Latin America, even though that we have more population, we can also see how countries is decreasing the fertility rate already now in 2025. What the World Health Organization shows is that 1 in every 6 couples are going to have difficulty trying to conceive. That's 50% of the population. Even though there are several factors that impact fertility, I wanna talk about 2. First is about both the couple in terms of weight. There's so much evidence showing us that depending on the BMI of a patient and BMI of her partner, it affects fertility rates. And when the BMI is so high, it's up to 2 to 4 times more complicated to get pregnant. But not only that, the patients are coming to us in a fertility clinic later in life than what it used to be. In the 90s, the average age of when a patient underwent fertility treatment, it was basically 5 to 7 years younger than now. And we see that because we can determine the average age of when a patient or a couple undergoes an IVF cycle. In Latin America, or in the US and Canada, where basically what we're seeing is up to 3 out of 4 couples are having babies later than 35 years old. And we are not, humans are not made to have babies after 30. The best moment when we should be having babies is between 25 and 30 years old. And basically no one right now wants to have babies at 25 years. In Mexico is actually what we can also see is that the more school are the patient, the less the more time they wait to have their first baby. And we've been seeing this for the past few years. So what are the causes why a couple can get pregnant? We basically see 5 reasons why. First, ovarian causes, either ovarian reserve or ovarian function or anything related with the ovary. Second, the tube, the fallopian tube, either is blocked, is inflamed like an salpinx, something related with the fallopian tube. 3, something related with the uterus, something related with endometrium, with a polyp, with a fibroid, adhesions, anything in the uterus. 4, we have to remember that this is about 2. So we'll always have to look at the partner 2, at the male partner. And about 1 every 4 cases, we can see that there is something on his side. And 5, 10% of the couples that we see in everyday practice, there's no specific reason, and we cannot find a specific reason. Something I like to talk with my patients is that it's not the same as to have ovulatory cycles, which means that we have an ovulation and we have a period, and it's not the same as fecundability, which is the chances of getting pregnant every month that we try. So we have ovulatory cycle up to 50, 55 years old, but that doesn't mean that that egg can implant or that egg can be fertilized, which means that the fecundability of those eggs finishes way earlier than that, about 38, 40 years old. That's why always I like to bring two very important concepts: the concept of ovarian reserve and the concept of ovarian quality. First, the ovarian reserve are all the oocytes or eggs that a woman is born with. We know now that we have around 2 million eggs when we were born. And then by the time of first period, 12, 13 years old, we already have only 500,000 eggs. What we know now is that even though we know there's one release of a mature egg at the middle of a cycle, we know that there is an intermediate phase that we call the antral stage, in which we can see 8 to 10 eggs or 8 to 10 follicles. And out of one of those is the one that's going to ovulate. And the ovarian reserve, the functional ovarian reserve, are those antral follicles that we can count on an ultrasound or we can measure in an anti-Mullerian hormone, and are the one that are going to tell us about the probability of having a pregnancy in the next few years. On the other side, we have the concept of ovarian quality. And it's important that we don't see eggs as having good, more or less good quality or more or less bad quality. For an egg or for an oocyte, it's either good or bad. There's no middle point. Either an oocyte gives us a baby or does not give us a baby. What changed? Why the reason why the quality of the eggs decreases with age is because it decreases the proportion of good quality eggs with bad quality eggs. What I mean is that, for example, when we are 30 years old, from 10 eggs, 3 are gonna develop into an abnormal embryo, an aneuploid embryo, and 7 are gonna develop into a euploid embryo, into a normal embryo. And this proportion starts moving with age: 70-30, 60-40, 50-50. We reach the 50-50 around 38 years old. And after 38 years old, then we have more chances of ovulating an abnormal egg that will become an abnormal embryo than having a normal embryo. And this is the main reason why a patient 42, 43 that has 80% of her eggs abnormal is very difficult to have a normal baby at the end of the pregnancy. And for all this, we need biomarkers. We need tests that we can rely on to be able to determine what's going on and what we want to determine. So we need 3 characteristics in these biomarkers. First, that they're accurate, that they can detect. We need them to be accurate. We need them to detect high and low levels with the specificity of what we want to see. Second, we want them to be reliable. That doesn't matter when or how we test them, are showing the result that we want, that is actually going on. And 3, that they're stable, that they can be measured anytime we want. And all these 3 characteristics, we need them in terms of what we do in terms of gynecology. And we want to talk, the things that I want to talk to you is about irregular menstrual cycles and how we can have a diagnostic approach in these patients that are not ovulating properly or are having irregular or no cycles at all. And basically, we need to think in 5 different reasons. First, pregnancy. Every time a patient does not have a period, we need to rule out a pregnancy. Second, we need to rule out endocrine causes like prolactin and hypo or hyperthyroidism. 3, we need to evaluate the HHO axis. We need to determine FSH, LH, estradiol, progesterone, and sometimes AMH. 4, we need to go to the ovary. We need to rule out ovarian causes like testosterone, and we need to see how the testosterone, SHBG, the sex hormone binding globulin, or the DHEAS are being secreted. And 5, it's going to be about the uterus. We need to see the endometrial lining. We need to see the myometrium to see if we have any fibroids, any polyps, any adhesions. So first, we need to rule out a pregnancy. And one concept that I always like to talk about is the doubling of the ACG. I know we all look at the doubling of ACG like it's something that we need to see. Once we see a pregnancy, we always ask the patient to repeat the beta ACG to be able to see if the prognosis of that pregnancy is okay, is good. But we sometimes forget that this article was published 40 years ago. We actually tried to make it more to recent information, to recent research, and what we did is we only consider frozen embryo transfer, in which we have a euploid embryo transfer, in which we had a normal embryo transfer, and then we determine if that doubling of ACG was something that we should be looking for. And what we were able to see is that when the percentage increase was 35-36%, we still have a 50% probability of a good pregnancy. And even though we had 100% increase, which what we were looking at doubling of the HCG, we only have 75% of probability of an ongoing pregnancy, which means that we definitely need to do serial determination of ACG, but not having a full doubling doesn't mean that is bad prognosis. Now, in terms of endocrine causes, we need to rule out thyroid disorders, hyperprolactinemia, PCOS, and premature ovarian failure. In terms of thyroid disorders, we have either hypo or hyperthyroidism. When we see a patient with hypothyroidism, the reason why they have irregular menstrual cycles is because first, they have an increased TSH, which means that they're going to have a low T4, and secondary to the increased TSH, we're going to have more release of TRH in the brain, in the hypophysis, in the hypothalamus, sorry. And then this increase in TRH is going to decrease the pulsatile secretion of GnRH, which in turn is going to reduce FSH and LH, and then we're going to have an ovulation and irregular menstrual cycles. On the other side, in hyperthyroidism, we're going to have an increased free T4, which is going to decrease TSH, and then it's going to decrease the secretion of GnRH by the hypothalamus. All these at the same time is going to increase the the sex hormone binding globulin, and this is going to affect follicular maturation because we're not going to have enough estradiol. At the end, both situations are going to alter the axis and the metabolism of estrogen. Therefore, every time that we have an irregular menstrual cycle, we need to rule out hyperthyroidism by requesting a TSH level or a free T4. Second, hyperprolactinemia. So basically, the reason why we could have high levels of prolactin is going to be either pituitary adenoma, some medications, some drugs, or like we just review, hypothyroidism, because it's going to alter the secretion of GnRH. The mechanism is going to increase prolactin. That's going to inhibit the secretion of GnRH. This is the alteration of the pulsatile secretion of GnRH is going to decrease the production of FSH and LH, and this is going to end up in an ovulation. What we need to do is to request a fasting serum prolactin level, but we need to remember that the prolactin has a circadian rhythm. So the moment that is in which is more stable is between 8 and 10 a.m., and we also need to remind our patients to not do a lot of exercise the day before, to not have sexual intercourse the day before, or any breast stimulation. Also, if possible, not do the test in which we had a really emotional stress day the day before, because we're going to have altered levels. Also, when we do not have symptoms, meaning we have a very low increase in prolactin level, meaning 35, 40, or up to 50, that means that we're not going to have the symptoms yet. We need to rule out macroprolactinemia. Remember that macroprolactinemia is the inactive form of prolactin, and if we can determine that the macroprolactinemia is high, macroprolactin is high, that means that prolactin is not high, is low, and that's not going to cause symptoms, and we do not need to treat these patients. Now, going back to basics, how a menstrual cycle works. And I want to put these levels here because at the end of the talk, we're going to review some clinical cases, and I want you to have the normal value. I know that most likely most of you will know, but just to make sure, remember that the normal on early follicular phase, meaning between second and fifth day of menstrual cycle, a normal FSH is less than 12. LH is less than 12, estradiol is less than 80, and progesterone is less than 1.5. Now, another cause of endocrine disorders that will cause irregular menstrual cycles is going to be PCOS, polycystic ovarian syndrome. We all know that the diagnosis is made through Rotterdam criteria, which means that we need to determine an ovulation, a hyperandrogenism, either clinical, which could be what it's going to be acne, alopecia, or hirsutism, or ovarian with the polycystic look-alike ovaries. Sorry. Also, in which when we do not have clinical hyperandrogenism, we need to rule out biochemical hyperandrogenism. And we're going to do that determining total testosterone and free testosterone. When these two are high, that's all we need to do. If they're not elevated, then we need to order androstenedione and dehydroepiandrosterone sulfate in case we need to rule out hyperandrogenism. It's always also important to remember that when a patient is under oral contraceptive pills, we need to stop them at least 3 months before, in able to have a good an interpretable result in the labs. Another hormone that is being used now is the AMH, even though it's still not in the guidelines as a diagnostic test for ultrasound for PCOS. We do use it in the clinical practice because we basically know that a very high AMH, meaning more than 5 nanograms, most likely is PCOS. So it's important that we use ultrasound or AMH, but never both, because that's we need to avoid an overdiagnosis. And AMH is not ready yet for being used by itself to diagnose a patient with PCOS. The other part important about PCOS is that it's also a metabolic syndrome. It's not only an ovarian syndrome. And most likely, most patients with PCOS are going to have either glucose intolerance or even though diabetes. So every time that we make a diagnosis of PCOS, we need to determine the glycemic status. So we need to evaluate H1C and insulin and a lipid profile in all our patients. Lastly, also another endocrine disorder that causes irregular menstrual cycles is premature ovarian failure, POF. Basically, it's patients younger than 40 years old with amenorrhea of more than 4 months, in which an FSH level is higher than 40 in two separate measurements within 1 month, after a month of doing each measurement. These patients are also have a low estradiol. It's very important in these patients to determine AMH because most likely AMH can determine patient as risk of ovarian failure because we're going to see a change in AMH first than in FSH. And this is very important because if the patient wants to do any fertility preservation, we're going to be able to do it once we see a lower AMH instead of waiting until the FSH is higher. Now, the problem with AMH is most likely none of us know the average level and per age that every patient needs to have. And we tried to do this a few years ago. In 2020, we published this paper in which there are several normograms in the literature. There is one normogram in the US. There's one normogram in Europe. There's one normogram in the Middle East. But we tried to have our own normogram in Latin America. Now we did it here in Mexico. And we collaborated with a lab. And what we did is we analyzed more than 6,000 measurements of AMH, and we were able to determine what's the average value at each age. In this manner, we can counsel our patient, or even though this is public, so any patient can go to any random lab, do an AMH, and they can see if they're above level, lower level, and if they need to do a fertility consultation because they're having a lower ovarian reserve. Now, let's talk about some clinical cases to make it more practical and more decision-making. So like I said, we had abnormal levels, FSH lower than 12, LH lower than 7, estradiol lower than 80, and progesterone lower than 1.5. Therefore, this patient is on early follicular phase, right? We have low FSH, low LH, low estradiol, and low progesterone. Now, what happens if we have higher FSH of 8, normal FSH, a higher LH of 25, then we have an estradiol of 280, a progesterone of 0.5. If we go and see this figure, we can see that FSH is going to be either here because it's low, or here because it's low, or on the luteal phase. But then we look at the LH that is 25. So there are two options. Either it's on rising or lowering already. So it's going to be around this point. And if we have estradiol of 280, we're gonna know that the estradiol is higher. So definitely it's going to be on the rising part of the LH cycle. And with this, we already know that we have a patient in late follicular phase. It's basically pre-ovulatory. Now we see an FSH of 8, an LH of 22, an estradiol of 130, and a progesterone of 2.5. See, if we have an FSH of 8, that means it's either here, or at some point in the luteal phase. We see an LH of 22. Again, either increasing or decreasing. Estradiol is not as high as usually when it is ovulatory, so most likely is on the decreasing phase of LH. And once we look the progesterone, which is 2.5, we already know that are in the luteal phase, right? So it's around here, LH is around here, estradiol is already lowering, and the progesterone is already increasing. Therefore, we have an early luteal phase post-ovulatory. Case 4, we have a FSH of 9, LH of 8, estradiol of 70, progesterone is 5.5. Just by looking at progesterone, we already know that we are in the luteal phase. Estradiol is low, LH is low, FSH is 9. Therefore, we basically are in the late luteal phase. We're about to have our next period. In this next case, we see an FSH of 15, LH of 8, estradiol of 70, and progesterone of 0.6. So if progesterone is negative, it means that we're not yet on the luteal phase. We're basically in the follicular phase. If estradiol is low, which it means that we are on the early follicular phase. So if we see a higher FSH, that means that we have some indication of ovarian failure, on ovarian insufficiency. When this patient has FSH of 7, LH of 9, estradiol of 130, and progesterone on 0.6. Again, progesterone is negative, so that means that we're in follicular phase. Estradiol is high, but FSH is low. So this means that at some point, the FSH responded, estradiol responded, but already made the FSH to go lower. That's also an indication of ovarian failure. Case 7, we have an FSH of 5, LH of 11. This brings the first yellow flag. This is not normal. It's very common in PCOS. With low estradiol, low progesterone, that means that we are in early follicular phase in a patient with probable PCOS. Finally, we have a patient with FSH of 5, LH of 6, estradiol of 200, progesterone 0.7. First, progesterone is negative. We again are on the follicular phase. Estradiol is high, which means we are at some point here, but LH is still low, so we're not preovulatory. We are around here, so we are in late follicular phase. For more complex cases, so we have here a patient that is called Mariana. She has 20 years, and she comes to the consultation with irregular menstrual cycles. She tells us that she has a cycle every 40 to 60 days, every month and a half, 2 months. She has a BMI of 34, and we can see that she has acne and some mild hirsutism. Therefore, we perform some studies. We first rule out a pregnancy. Beta HCG is negative. Then we measure FSH and LH. We can see that there's a little bit of an inversion in LH and FSH. We determine that prolactin and TSH are normal. We have a slightly elevated total testosterone, a low sex hormone binding globulin, and then we have a high AMH of around 6 nanograms. Therefore, we have low sex hormone binding globulin. That means that we're going to have free testosterone and active testosterone. That's why it's elevated. Normal and endocrine options. And then we can see with this panel that we have a patient that has PCOS. She has all the criteria. She has an ovulation. She has clinical hyperandrogenism. And I forgot to mention that in this, we can see in this figure that we have a lot of follicles, a lot of antral follicles. Why is the relevance of ordering the whole panel? Is because we need to rule out hyperprolactinemia. We need to rule out thyroid dysfunction, and then we need to confirm biochemical hyperandrogenism. And this is important because even though we're gonna recommend diet and exercise, but we can ask her to, instead of using any contraceptive pills, if we can recommend a contraceptive with anti-androgen progestin, it's gonna be a better, more. She's gonna have a more effect or in the acne and in the hirsutism that she has. Second case, we have a Carla, 34 years old. She has trying to become pregnant for the past year. She refers regular menstrual cycles, and her partner has a normal semen analysis. We do an AMH. We can see that it's 0.4 for 30 years old. She's lower than average. We ordered an FSH of 16, which is also not normal. Estradiol is 100. So even though the estradiols already start increasing, so that means that FSH is even more higher than that, because remember, estradiol inhibits FSH secretion. Also, we need to rule out TSH and prolactin, and we need to rule out a pregnancy. This means that our patient has a premature ovarian failure, even though we barely see it in the levels, but we also are seeing it on the AMH level. So this patient needs to undergo directly to IVF. Lastly, we have Sophia, 30 years old. She has amenorrhea for 6 months, and she has spontaneous galactorrhea and occasional headache. She doesn't use any contraceptive pills or other medication, and she's not pregnant. We see a serum prolactin of 92, which is very high, TSH of 7, a low T4, a low FSH and LH, most likely due to the high prolactin, and low estradiol. So we can determine that this patient has hyperprolactinemia. It can be she has a headache and she has hypothyroidism. So in this patient we need to do an imaging test, because we still don't know if it's only the hypothyroidism or she still has a pituitary microadenoma. So we need to refer her to an endocrinologist. So we need to do the whole panel to be able to determine what are the options for these patients in terms of diagnosis. So to conclude, like I said, all the biomarkers are important because we need to do an integral and comprehensive approach in our patient. They're going to allow us to detect any of the problems, any of the dysfunctions that we have in the reproductive tract, and doing targeted biomarkers is going to allow us to save time and improve accuracy in our patients. Each of these tests has their own clinical utility. Obviously, the ACG is going to help us to confirm a pregnancy or to evaluate the progression of a pregnancy. The estradiol level is going to talk about ovarian function and respond to stimulation. FSH and LH are going to help us for ovarian function. LH is going to help us also in PCOS. Progesterone is going to help us to confirm ovulation in days 21 of the menstrual cycle when we want to do it. Prolactin obviously is going to help in cases of hyperprolactinemia. Testosterone to rule out biochemical hyperandrogenism in cases of PCOS. The same with sex hormone binding globulin and DHES. Obviously, a thyroid profile is going to help us determine another causes of menstrual irregularities. And patients with metabolic risk, we can order the HbA1c. Thank you for your time, and I'm here for any questions that you guys want to have.
Hi, doctor. Thank you so much for being here. I mean, so we have some questions from the audience.
Perfect.
So the first question they have is, where can the lab provide value in patient fertility assessment evaluation? So it can be the decision-making support, or where can the lab provide a value to the patients?
Yes, of course. So I think it's very important for our patients to be able to have these tools, to be able to, as simple as ordering a test, to be able to help them to understand, to diagnose with very precise, in a very precise way, a simple test. What I mean is a patient that is not ovulating, a patient that needs to be undergoing an stimulation, or simply because she has abnormal cycles, ordering TSH, ordering prolactin. I mean, it's very important that we have in mind this test so we can help our patients.
Got it. Thank you. So we have more questions here. So next question. I would like to know how a short luteal phase can impact fertility and how to overcome this. What if progesterone levels are within range but at the lower end?
So, I mean, when we have a short luteal phase, what it means is that we don't have enough progesterone maintaining the corpus luteum. Yeah, this is a very complicated situation, because we now know that providing progesterone to have a longer luteal phase is not going to be enough, because most likely when we don't have enough progesterone, it is because we have a low oocyte quality. So that is not going to be a good cycle. That specific cycle is not going to be a good cycle. Theoretically, we do not have short luteal phases. It's either another reason why the cycle is not having the correct length. I would advise here to first check the first half of the cycle, the follicular phase, because most likely more than a short luteal phase, it's a short follicular phase, also related to egg quality. So if you want to, I mean, infertility counseling, on infertility treatment, we don't test progesterone on cycle day 21 anymore, because it doesn't add value by itself. What we need to understand is what's changing the follicular phase, so we have shorter cycles. I mean, in a patient with 24-day cycle, it means that the follicular phase is being shorter, and the luteal phase is still 14 days. So here, my advice would be to look at what's going on in terms of FSH, measure FSH on day 3, most likely it's going to be high, measure AMH, or ovarian reserve. I think that's going to give you the answer about why this particular patient is having short phase.
Okay, thank you. Thank you, doctor. Next question. Are there any biomarkers for endometriosis, or is it still scans and biopsies?
No, we don't have a test, a biochemical test right now that we can use for endometriosis. Probably we will have in the next few years, but right now we still have to do ultrasound scans and MRIs. I think it's still the best way of diagnosing a patient with endometriosis.
Got it. Thank you. So next question. Statistics show that about 70% of women with PCOS remain undiagnosed globally. How we can improve diagnosis rates? So what role can biomarkers play in this?
Yes, I mean, this is the most complicated situation about PCOS, because we still, as its name says, it's a syndrome. So it's basically some symptoms and some signs that determine that a patient has PCO. So if we don't have a specific way of diagnosing a patient, we're still not going to have a specific way of treating a patient with PCOS. And this is the complicated situation. Right now, What the guidelines say is that we still have to look for the three situations: oligo and ovulation, a polycystic ovarian morphology, and hyperandrogenism. In this moment, we still have to be looking for this situation, and this is the complication, because there's no other way right now of diagnosing PCOS. We have to be thinking about PCOS, and also we have to be thinking about not overdiagnosing patient, which is also a complex situation. So my advice here would be just run all the tests, the metabolic test, the endocrinology test, ultrasound, and try to be very specific about diagnosis.
Thank you. And there is a question similar or related to the previous one. So we have this question, like numerous conditions that cause infertility are directly related to elevated risk for other diseases later in life, cardiovascular, metabolic, cancer, etc. How can we improve patient follow-up and handoff between medical specialties to ensure that they are being risk stratified in order to drive prevention and or early diagnosis?
I think this is the base of modern medicine. I think we need to be, with thinking about integrative medicine, we need to be a team treating our patients. We need to have a neurologist. We need to have a geneticist. In more complicated patients, obviously, we need to, as the presenter, as the whoever is asking this question is saying, in specific patients with specific risks, we need to involve other specialties. We need to think that we don't have the responsibility of treating everything as doctors. And thinking this way, thinking as a team, I think we're going to be able to help in a more rapidly to our patients. I mean, identifying specific diseases with an immunologist, for example, we're gonna be able to help these patients more efficiently.
Thank you. We have one more question. Are there any critical areas in fertility that would benefit from development of diagnostic biomarkers?
Yeah, I think. Well, I mean, I think at some point, and it's also related to endometriosis, for example, or to adenomyosis. If we can have a test that identifies molecular changes in the endometrium, or molecular changes in the ovary, or molecular changes in the uterus in general, it's going to be very helpful. I mean, I don't know if we're ready for that. I don't know what the companies are doing, but I think with the tests that we have now are functional. I mean, it tells us about the functionality of a specific situation that is undergoing in the ovary or in the uterus. But we need more tests that can predict pathology. We need something on the endometrium that can tell us that a polyp, for example, is forming, or an adhesion, or simply inflammation as endometritis. That would be an amazing breakthrough in diagnosis. I would say that, yes.
Okay, great, thank you. And so that was the last question, but just to close and also to tell to our audience, because we have also physicians and we have people from the lab. So what recommendation would you give them to, work to get better together and provide better results to the patients and also the physicians that are requesting the diagnosis test?
That's a very interesting question, because I think if we can structure our day-to-day in a way that all the specific areas of a team or of a clinic can work in a specific what's the word? Let me think about the word. But what I'm trying to say is that we need to listen to every team member that is telling us to work in a better way. Sometimes we as doctors have the responsibility of making a decision, and we sometimes forget that nurses, lab technicians see things because they process these tests more time than we do. So I would say that it's very important for a specific center or a specific clinic to listen to every team member and how to improve a specific protocol. And that way we're gonna advise our patients more efficiently.
Thank you, Dr. Rodriguez, for the presentation. It was a great session. Thank you all the audience for attending, and see you next time. Thank you.